Well, thank you very much. It's a pleasure to be back. I love speaking with this group, and of course, I love speaking on this topic, which is very exciting. You will notice that I've probably been here maybe 4 or 5 years now, and I'm still an assistant professor, so it's fun being a faculty member at Duke. No such thing as advancement or promotion. So just to make this fun and entertaining for you, I have also brought along a little friend, which is the Magic 8 Ball, and along the way we'll ask the Magic 8 Ball some questions. That's just to make sure that you guys won't fall asleep in this extremely dark room, which if I stop for more than a minute in a dark room, I'm totally asleep and snoring. So, all right, so this is my disclosure slide. I do interact pretty frequently with most of the companies who make many of the drugs that I'll be talking about today. Some of them are investigational still, so that is also a disclosure. But my relationships have always been scientific, either participating in research or as scientific advisor. I'm never marketing. So you may wonder whether or not you can trust me given all of these conflicts. I'm clearly conflicted, but I think there's no doubt about it. Trust everything I say. All right, so the goal today is to discuss a little bit of the natural history and really to focus on the changes in clinical practice as we've gotten new drugs available and had access to these newer therapies. We also have had a bit of a change in how we approach staging of liver disease, and I think it's always really important to providers, especially in infectious diseases, to talk about how that's evolved over the past, really 2 years in large part. I know we discussed this some last year. I try to pull in the AASLD IDSA guidelines for those of you who are unaware. The AASLD, which is the American Association for the Study of Liver Disease, and the IDSA, the Infectious Diseases Society of America, came together under the leadership in large part of David Thomas in infectious diseases at Johns Hopkins to create a guideline. And I think the idea behind this guideline was really to mimic the DHHS HIV guidelines, which is a living online document that can change daily. With the idea that a printed document that gets printed every 5 years or updated every 5 years would be of no use to any provider clinically because things are changing so very rapidly. So I would highly recommend that you look at this website if you have not yet. It covers everything from screening and testing to treatment of HIV, HCV monoinfected, co-infected, other special populations, treatment of acute disease, and management after cure. So it covers really the gamut of what you would need in terms of the management of patients with hepatitis C. We'll look very closely at a lot of the trials that support the use of these drugs and what the guideline recommendations are currently for managing and treating patients with HIV, HCV. And then really I think what becomes increasingly the only thing to talk about these days when you're talking about treating an HIV patient is the drug-drug interactions, which is really the only difference at this point between treating a patient with HIV and hepatitis C. So we'll start off with kind of the goal of treatment of hepatitis C. And these are just pulled excerpts from the guidelines themselves. So as many of you probably know, but to put it in words, the goal of treatment of an HCV-infected person is to reduce all-cause mortality and liver-related health adverse consequences, including end-stage liver disease, hepatocellular carcinoma, by the achievement of a virologic cure as assessed by SVR. So SVR is the acronym for Sustained Virologic Response. And this is someone who has an undetectable hepatitis C RNA 12 weeks after they have completed therapy. So they've been off drug for 12 weeks, and they are still undetectable. We used to use SVR 24, which was someone undetectable 24 weeks after the end of treatment. But I think to move trials along much quicker, to get access to these drugs quicker, I think there was a movement with the FDA, pharma, to try to move this timeline up, and I think we are all very, very confident with multiple studies now that SVR 12 equals SVR 24 at 99.8%. So this is really what I would call a virologic surrogate for clinical cure. We do cure and eradicate this virus, although we clearly recognize that patients are at risk who are at risk of re-exposure are at risk of reinfection. You can get infected with this virus over and over and over again. And in fact, one of the patient populations that we take care of as HIV providers, which are HIV-positive men who have sex with men, are one of our highest risk groups for getting reinfected with hepatitis C. So a lot that goes into treatment and cure. Treatment and cure is now the easy part. The harder part is having the conversation of, now what are we going to do to make sure that you don't get reinfected, to make sure that you're taking proper care of yourself and protecting yourself so that you don't get this virus again and again and again. And so you see the second recommendation here, which is an assessment of the degree of hepatic fibrosis using non-invasive testing or liver biopsy is still recommended. And we're going to talk about this, but the bottom line is that back when we used interferon-based regimens, which were quite difficult for patients to take, carried significant side effects and significant safety issues. In addition to the fact that when we were treating genotype 1 patients, which is the primary genotype that we're all treating in this country, the cure rate, if you were Hep C monoinfected, was 40%. If you were co-infected, it was probably more in the 15 to 20% range. And so the risk-benefit, we really had a serious risk-benefit decision to make. And so we really only wanted to treat patients who had clear evidence of progression of fibrosis. So that is no longer important to most of us. In fact, most of us strongly believe that if you have an infectious disease, and a viral infection that doesn't just cause liver disease, that causes significant extrahepatic disease. We know very clearly that hepatitis C causes significant neurocognitive disease, bone disease, associated with cardiovascular disease, diabetes, you name it, these patients get it. That even all of those things are important for cure of this virus, right? So now that the decision-making on using stage to decide whether you should get treatment or not is really, for most of us, no longer relevant. Now, of course, payers consider it very relevant because they don't want to pay to treat everyone. They only want to pay for people who have severe liver disease. But ultimately, for us as providers, you could argue, well, then why do you need a stage of liver disease if it doesn't matter if you should treat everyone? And the bottom line is that hepatitis C is an infection. Over years, it causes liver disease. And once someone has severe liver disease, although the liver is an organ that does regenerate, that is a very slow regeneration. In fact, long-term follow-up liver biopsy studies suggest that 5 years, 10 years down the road, not every patient with cirrhosis no longer has cirrhosis. In fact, the majority still have cirrhosis. So now the decision that we have to make is, do you have cirrhosis or not? And that's important for two reasons. One, we still treat you differently if you have cirrhosis based on the drugs that we use. And then two, we will manage your liver disease for the rest of your life, at least for now. I tell my patients, for now, it's for the rest of your life. 10 years from now, I may have a different answer, but today, it still matters, right? So I'm not trying to discern whether or not someone has stage 2, 3, or 4, which is what we used to do, because if you were 2 or higher, you went on to get treatment. Now I just want to know, do you have cirrhosis or not? And that actually changes the tools that we need, and the way that these tools perform can be quite different. So as most of you know, liver biopsy was our prior standard of care for assessing stage of fibrosis. And this has actually been very difficult for many of our ID or HIV providers, especially providers in more resource-limited clinics, because this is an extremely expensive test. And so most of our patients who don't have health insurance, there's no way we could get something like this. And the reason we needed something like this was because it truly was able to discern whether someone had F1, F2, F3, or F4, which is cirrhosis. So these are the various stages, pathologic stages of fibrosis. And back when we really needed to know whether or not someone fit here or here, the true only test who could do that with good certainty was a liver biopsy. And many places have used non-invasive tests for a long time, but they well knew that they were not doing a very good job of identifying patients and stratifying them appropriately. But now the question has changed. Now we don't care about whether we can put the line here. We care about whether or not we can put the line here. And these non-invasive tests that we have available actually do that much better than they do in putting the line here or here. So this shows you some of the tests that have been studied and that can be utilized that are serologic or based on a blood draw. That includes the APRI score, the Fibro test, or the FibroSure. And I think notoriously everyone recognizes that these tests don't perform as well in HIV-infected patients, and that is generally true. And that is in part because our patients with many of these tests depend on platelet count and AST, and many of our patients have elevated ASTs for various reasons, including other medications. And they often have lower platelet counts because of their HIV, their other medications, and these are two main drivers of these tests. But what I can tell you is if you look at how good they are at discerning cirrhosis, they certainly become closer to what we get for HCV monoinfected patients. And if you choose very strict cutoffs, so as opposed to using whatever you may see in the literature, or using the cutoffs that the Fibro test, which is a patented test that you can get from LabCorp or others, if you use cutoffs that are a little bit more stringent, you can actually be quite confident in the diagnosis that you're making of cirrhosis, yes or no. So I use an APRI, which is an AST divided by the normal upper limits of AST by your test, by your lab, divided by the platelet count, which is divided by 1,000, and you can find this online, Google APRI score, times 100. And what I use is if my patients have an APRI less than 0.3, I am confident, over 90% confident that they do not have cirrhosis. I can treat them as a non-cirrhotic, and I can cure them, and I can tell them that they generally do not need ongoing care for their liver as long as they don't have other reasons for liver injury, and we're going to get to this as it relates to HIV patients. Whereas an APRI score over 2, I think, quite confidently rules in cirrhosis. Similarly, a fiber test or a fiber score of 0.2 rules out, and this rules in. And so these are some of the tools that I use clinically to try to avoid liver biopsy or other testing. So what other testing do we have available? So we have available something called a FibroScan. I know UNC has a FibroScan machine. Duke has a FibroScan machine. The Durham VA has a FibroScan machine. They're increasingly becoming prevalent in the communities. Increasingly, I think you'll have access to these. But since most folks here practice in this area, you could refer either to UNC or to Duke. Or if you have a veteran, know that they can come to the Durham VA to get a FibroScan. And the FibroScan is a non-invasive technology that measures what I call the jiggle of the liver. Right? So if you think of the liver as like a plate with a little thing of Jell-O on it, and you move it and it jiggles really nicely. So as opposed to other things in the human body, jiggle of the liver is good. And the less jiggle, the more damage and scar. And I actually describe this to patients as when you think of like, the plain old Jell-O, and then you think of the Jell-O that's got like fruit in it. Right? So if you think of the fruit as the scarring areas, the more fruit that you put into that Jell-O, the less jiggle, and actually the more damage and scar, and the more that this machine, the FibroScan, will pick up on that difference. It actually is excellent at differentiating cirrhosis from no cirrhosis. And this just shows you the receiver operating curve for that this in green is actually deciding cirrhosis versus no cirrhosis, and you can see that it's well over 90%. Whereas if you tried to use it to differentiate what we used to use for liver biopsy, which was F01 versus 234, you can see it's quite poor, right? You would never want to use this test for this question. But now that this is our question, many of us have stopped doing liver biopsies altogether and use these non-invasive tests. I usually like them in combination when they don't fall in the extreme ranges that I gave you before. If I have an APRI of 0.3 or 2, I don't actually get a FibroScan unless there's something else that makes me nervous. But when they fall in the gray zone, which will be about 70% of your patients, then I go on to a FibroScan. And most trials in the United States now we don't do liver biopsy anymore even for clinical trials. We use concordance of these non-invasive tests. So I would definitely encourage you to refer to your clinics that have access to these when needed in place of liver biopsy. All right, so in terms of treating HCV, so as you know, that one of the things in the guidelines that we provided was a way to prioritize patients. And the idea behind this was every clinic has limited resources. You have 1 or 2 providers. You may not have the ability to treat every single patient who walks in your door. What we want to do is provide guidance to providers to understand who should I be treating right now and who should I be saying, we're going to start you in 3 months or 6 months once we have our sicker patients underway because I'm only one provider and I don't have a lot of help in getting this done. And that was the idea behind this. We had the highest priority patients who were those with severe liver disease, stage 3, 4, and then we had high priority patients, and this is where HIV co-infection falls in. As most of you may be aware, payers have taken this and used this highest priority as saying these are the only patients who deserve treatment today, and they will deny coverage for patients who have anything other than F3, 4 disease. North Carolina Medicaid, as many of you probably know, has expanded to F2. That was very gracious of them. But ultimately, if you want to treat a patient who's HCV monoinfected, who has F0, 1, and in many parts of the country 2, you'll be telling your patient that they're going to have to wait until they develop severe liver disease to get treatment, which I can tell you, having had that conversation, is not an easy one to have. Luckily for our HIV-infected patients, the majority of payers will approve, although I have current denials from North Carolina Medicaid actively for my HIV-infected patients where I write very nasty letters after I put my head back on because it just exploded when they denied coverage for my HIV patients to say, this just ain't right. So it takes a lot of effort, but ultimately you should be able to get your HIV patients covered today regardless of stage of liver disease because patients with HIV have more accelerated disease and because they actually suffer a lot of these extrahepatic consequences that I described, the neurocognitive disease, the bone disease, things like that, that are clearly related to the dual infections, both of these dual infections. So this is just to bring home the point as to why HIV-infected patients might be highlighted as a high-priority patient population. Many of you know the DAD study, first published in 2006, which showed these original data that patients with HIV died of liver disease more so than anything else, and obviously secondary to AIDS. With a reevaluation of this in 2014, you can actually see that liver disease deaths are dropping, which is fantastic. As you all know now, the leading cause of non-AIDS death is, in fact, non-AIDS related malignancies. Although liver cancer is a significant player in this. And so we are making headway with liver-related diseases, and I expect with the access to DAAs, we can and should see this significantly decline. And that's the beauty of being able to cure an infection, is that you can significantly prevent these outcomes in the long term. So the one thing I want to bring him a point to is there's a study that was presented at CROI this year that I think is actually a really important discussion to have, and as providers we have to think about this. We know that HIV co-infected patients have more accelerated liver disease. We do not understand this completely. We know that HIV can, in and of itself, activate various pathways within the liver that leads to scarring independent of hepatitis C. We know that antiretrovirals can be quite toxic to the liver. We know that patients with HIV do drink alcohol more than patients without. There are probably a lot of things playing a role here. We know LPS is quite toxic to the liver, and that patients with HIV, especially poorly controlled HIV, have higher LPS, lipopolysaccharide, in their bloodstream. So we don't understand all of this. And as providers who treat and cure these patients, when we tell them, well, you know, you're stage 2, and now we've cured you, so you can just walk away into the sunset and not worry about your liver disease anymore. And I think this study brings home a point that luckily all those patients continue in care, but as the provider's taking care of them, even when their hep C is gone and you're screening for reinfection, remember that they may have other causes of liver injury. So they may have non-alcoholic fatty liver disease because many of our patients are overweight, but especially our HIV patients who are on these drugs that have significant metabolic consequences. So there's a lot here that we probably need to keep an eye on them. Luckily, as opposed to a hep C monoinfected patient who literally may just go out of care completely, at least our HIV patients remain in care. But as providers, I would say keep an eye on that liver, and elevated liver enzymes post-cure should lead to a referral and ultimately possibly a liver biopsy to understand what that is. And I have found that with a significant minority of my co-infected patients, once we cure them, their liver enzymes do not normalize. We blamed all that on their hep C. Now the hep C is gone and it's still there. And that really does warrant a full investigation to understand what's going on. And that's kind of what this study got to. What they did was they modeled the idea of cure in a patient with HIV. Most models that look at this say once you're cured, your risk of fibrosis progression goes to 0. So that presumes no alcohol and no other liver injury. Well, if our patients have accelerated disease, there's probably some other injury going on that we haven't put a name on. It's probably complicated, it's probably complex. So instead of saying 0, they said liver fibrosis progressions decreases tenfold, which sounds pretty significant to me. You know, in models, they can move things up and down and all around. So this is what they looked at. So they don't go to complete 0, but they drop significantly, but this recognizing there's something else going on in that patient with HIV's liver. And this is, I think, a pretty terrifying look at what they predict. So this shows you patients who get treated. So I'm going to show you, just focus here on the kind of darkish yellow bar here, the red bar here, and the maroon bar here. And this shows you patients who have decompensation, liver cancer, and liver death, depending on whether they get treated when they're an F4, an F3, or an F2. And this shows you that if you wait until an HIV patient is F3 or 4, they are suffering significant liver disease consequences. So that shows that you are waiting way too late to treat that patient if you wait until that stage. And in fact, you could argue that waiting until an F2 really carries a significant burden of high morbidity and mortality. And then even more so, what they showed was that if you wait, so this is actually looking at diagnosis, 1 month post-diagnosis, 1 year until they're F2, 3, or 4, you can see that not only do you see an exceptional increase in rates of liver-related death, but that most of these patients suffered this even after their cure of hepatitis C, which again get to that point that these patients have other things going on, and that treating them early, very early in their disease course is critically important. So this gets to the whole idea that every patient that walks in your clinic with hepatitis C, you should consider them a candidate for therapy and be as aggressive as you can in figuring out how to get them access to treatment, as long as you know that they'll take it and their HIV is controlled and those other things. I think this is pretty scary data. So this is, now to get to treatment, an excerpt from the guidelines, and I will say we were a little slow. Our first iteration of the guidelines actually made different recommendations for HIV patients because we had very different data. I think everything has evolved, including the FDA, in terms of their view of HIV patients in clinical trials and how they should be treated. And ultimately, the recommendation by the guidelines is that HIV co-infected patients should be treated and retreated the same as persons without HIV after recognizing and managing interactions with antiretroviral drugs. And so we essentially refer you to the Hep C recommendations, and there is no longer any difference in treatment. And I think I will show you now the data that brings home the point that HIV is no longer a predictor of poor response to treatment for hepatitis C. And for that reason, which has always been a reason for providers and patients alike to not want to get treatment, we really need to focus on getting these patients access to care. So we're going to take a step back quickly. I know not everyone in this room is using these drugs actively, so just to bring you to the point, this is always an easy talk to give to HIV providers because the idea of direct-acting antivirals and targeted therapies, is like second nature to all of you. So this is a different virus, though, hepatitis C. Welcome. Introduce you to hepatitis C, HIV providers. So there are 3 primary mechanisms of action for these new drugs for hepatitis C. And you guys saw this slide last year. So we have the NS3/4 protease. So we have inhibitors to the protease. These were the first DAAs approved back in 2011. We have NS5A inhibitors. And we have nucleotide polymerase inhibitors. So you can think of, proteases are proteases. You can think of these polymerases like reverse transcriptases, right? It's the same exact enzyme, just a different virus. And then we have 3 primary classes, and the nukes come in nuke and non-nuke, and we'll see examples of all of those today, right? So there are differences between these, and the idea, just like in HIV, is to use them in combination, and depending on the genetic barrier to resistance, which most of you feel very comfortable with, you can actually get away with 2 drugs in the example of HCV if you have a drug that has a very high genetic barrier to resistance. If you don't have a drug with a high genetic barrier to resistance, then you need usually 3 DAAs to get through this. And then I'll show you how the bar keeps changing. The more you add on, the higher the cure rate for many, but also the shorter the course of therapy. And we'll kind of look into the crystal ball as to where this goes from here. But this is the current treatment paradigm. We actually have a bit of a list of drugs that we can now use that are all, I do believe as a provider, are equally effective. They may be a bit more complicated, one across the other, but the bottom line is that they are equally effective and offer cure to over 90% of patients, no matter which you choose. But as you can see here, there's a little bit of a difference in the combination. So the nucleotide polymerase class has been shown now to be a very potent and have an exceptionally high barrier to resistance. So you can actually just take a nuke and combine it with an NS5A, an NS3/4A, and you can actually achieve over 90% cure rates in 12 weeks. If you have a non-nuke, at least for now, and not a nuke, then you may need 3 drugs, okay? And you may or may not need ribavirin. But ultimately, you can still achieve over 90% cure in 12 weeks. And then this down here is you can actually use a single DAA with ribavirin to treat genotype 2 and 3 disease. And so there is quite a difference now. We have 6 primary genotypes that we treat. And we do actually treat them all slightly differently because these DAAs do have differences in their activity against the different genotypes, which is, we do see that technically in HIV 1 versus 2, except for that we don't treat a lot of HIV 2 in this country. We have a lot more variety in Hep C in this country than we do of HIV. So this is kind of where we stand, and now we're going to put some faces to the name here. And I'm just showing you this, that pretty shortly in 2016, we will also have the combination of an NS5A and an NS3/4A. So you can see it's pretty exciting because you start getting a lot of choices and a lot of mixing and matching that can go on. And by mixing and matching, I mean the company tells you what you use, and that's what you use, because the mixing and matching that we do in HIV is not really financially possible in the HCV world. So this is kind of putting face to name here. So you can see here that we have, again, the NS3s that we talked about, the protease inhibitors, the NS5As, the non-nukes, the nukes, and still that good old ribavirin. If you're a friend of the underdog, then you are a fan of ribavirin because it costs like, I don't know, $3. And some of these, $82,000, $94,000 regimens still need it. So we have combinations, as you can see here, that use an NS5A and the non-nuke. And the nuke. You can see here again a combination. This is the one that uses 3 drugs. But this shows you some of the names, and I certainly don't expect you to go home with remembering these names at all. So I've also added on here a new NS5A that should be approved. Sometime in August is the rumor, and so then we'll actually have the availability of 2 of these NS5A nuke regimens. So it's a pretty much a mix and match here, as you can see. So this is the data that we have to summarize HIV, HCV co-infected patients, and I put this up for 2 main reasons, maybe 3. So these are the FDA-approved regimens as of today, and you can see that as of today, 3 regimens approved, 1 phase 3 to support that approval. In fact, this regimen has never had, and I presumably never will have, HIV-infected patients in their clinical trials. And you can see that the cure rates actually were quite high in some observational studies presented at CROI, but the bottom line is that we are unlikely to see this, although until these two regimens were approved, this is all I used for a solid year in my practice, based on absolutely no data whatsoever other than some drug-drug interaction studies. And then you can see here that we are looking at cure rates of anywhere from 92 to 98%, which is quite exceptional. You can see here that we have 2 investigational regimens pending approval. And thankfully, it seems as the companies have come around, and already those phase 3s are done and have been presented. So declatosphere, as I mentioned, is NNS5A, will be approved by August of this year, again, is the rumor. Phase 3, 97% cure. And they just presented the phase 3 of Grazopavir and Elbasvir. So this is this combination I showed you that popped up in the corner, which is a protease inhibitor and an NNS5A combination. So this is actually what you could call a nuke-sparing regimen. Means something a little bit different to you guys than it does to me, but a nuke-sparing regimen, 95% cure. So very exciting numbers. And when these drugs get approved, we're actually going to have lots of data to help us understand how to manage these patients clinically. So this is the recommendations per the guideline treating patients today. And just a show of hands, how many of you guys have used these drugs in patients actively? Okay, so a few of you. So this is the recommendation for treatment of any Hep C infected patient. I just added the HIV in there. And you can see that this is actually quite simple. If you are a patient, you have a patient without cirrhosis who's genotype 1, treatment naive or experienced, then you can give them 12 weeks of any of these treatments and ultimately achieve over a 90% cure, which is quite fantastic. Now, there's a difference. This is a 1-pill once-a-day regimen. This is a 2-pill once-a-day regimen. This regimen for genotype 1As involves 4 pills plus ribavirin, which usually is 5 to 6 pills. And then their 1Bs do not need ribavirin if they're non-cirrhotic, so that's 4 pills. So you can see that it can be a bit more complicated depending on the regimen and depending on what your healthcare payer is. So, there's been a lot of aligning between payers and insurers, industry and payers, where this is probably a preferred regimen for some of your patients and this is a preferred regimen for others. This regimen, the Cimipivir-Sofosbuvir, as I said, was a favored off-label use regimen when these drugs weren't around because it was the only option you had for all oral treatment. But the problem is that it's now the most expensive regimen because it doesn't come as a pill or in a box from the same company, and so really increasingly is not used. But 12 weeks with over 90% cure is really quite fantastic, and this is pretty a simple approach to treatment, right? It does get a bit more complicated with future slides. And then, so I'm going to talk here, there's an asterisk, here for 12 weeks. So in the approval, this is the approved treatment with this drug, Ledipasvir-Sofosbuvir, but there's an asterisk in the package insert that says that you can use 8 weeks in treatment-naive patients without cirrhosis who have a Hep C RNA less than 6 million. And we're going to talk about this because for those of you who are doing this or getting into this, the bottom line is payers are taking this out of the package insert and forcing this on providers and saying, oh, yeah, you're approved, but your patient's approved for 8 weeks, not 12. And, I don't care that you have a, DO or an MD or a, whatever after your name. We actually make these decisions, not you. And this doesn't go over well for most providers, and certainly for most patients, because they defer to their provider, not to their payer, to make decisions about length of treatment. And the reason this is very important is that they're doing this to HIV patients, for which we have absolutely no data at all. And in fact, the data, in my opinion, would argue quite against this. And so that's the argument I'm going to make to you all today. So we're going to ask a couple of questions just to bring home the point that HIV patients can and are cured at the same rates as HC monoinfected. So question 1, did genotype 1 patients achieve the same SVR as 12 weeks of Ledipasvir-Sofosbuvir? And the answer, I think, you guys, yes? Overwhelmingly, right? I think there's one thing I'm quite proud of, which is that this is, I think, one of the largest, if not the largest, DAA all-oral trial in HIV-infected patients. And this is increasingly going to become an issue for us. You saw those phase 3 trials, which are great, but some of them are 170 patients, 200 patients. And the problem is those are good numbers, but some of these are getting even smaller. And now the FDA is essentially saying HIV is no longer a special population. All we need is some drug-drug interaction studies, and we need, 80 patients that show that you don't use HIV viral control, and then we're good to go. But they're also not forcing industry to include HIV patients in their registration trials. So our HIV patients are getting excluded from registration trials, and increasingly there's less onus for them to even do a phase 3. Right now, I think most of the companies are doing the right thing by doing phase 3s, but I have concerns that slowly we're going to see our HIV patients fall into these grossly underrepresented groups of patients, even though they represent, over 250,000 patients in this country. So you can see that it didn't matter whether patients were treatment naive, previously had failed a prior course of therapy, whether they had cirrhosis or not. You can see over 90% cure. And this is extremely exciting when you think about the fact that a treatment-experienced patient 5 years ago had basically no chance of cure. And they were going to sit there and wait until their liver failed and either they got a transplant or they died. So this is brought, I've had patients cry when they, that's what they were told. And many people sitting in this room understand or know people or patients or friends or loved ones who were told there's no hope, you're going to die, and they're still alive today from another virus. And this is now becoming true in hepatitis C, which is extremely, I think, exciting. So this is great, and the answer is yes, definitely. It's a smart 8-ball. So I do want to bring up this point because for those of you who follow this pretty closely, there was something about this trial that was very different than every other trial that's been shown. And that is when you look at, this is called a forest plot, and this tries to pull apart all the different predictors of responses to therapy. In the old days, there were lots of things that predicted failure. So having cirrhosis, previously failing therapy, being of African descent. What are some other things? This IL-28, this is a gene that you may or may not carry. All of those things have, quote unquote, gone by the wayside. When you have cure rates over 90%, none of those things matter any longer. And that's what we've been told, and that may well be true. But in this study of 335 patients, which included 115 patients of African descent, which is the second largest representation of any trial in the United States, we did find that the single predictor of failure was being African descent, or self-reporting as black race. And I think one of the issues here is that we have no idea there's no explanation to this as of yet. Most of us believe that this was going to be pharmacologic. So these patients all have HIV. Many of them were on efavirenz. There was an interaction with one of the Hep C drugs and the efavirenz. We thought that maybe those patients were getting lower exposures to the Hep C drug and therefore breaking through. And we know genetically patients of African descent have higher exposures to efavirenz in a significant percentage. But ultimately, population PK did not suggest that was true. There were 90 African-American patients in the non-HIV infected program that received 12 weeks of this treatment, and they had 99% cure. So we are now left, we're doing full genome sequencing and everything else to try to understand this. But ultimately, I've made two arguments. One is that we need to understand it, and the only way to understand it is to ensure that future trials adequately enroll patients of African descent. They carry a significant burden of the disease in this country, and yet are always a significant minority of every clinical trial. In fact, if you look at many programs, often patients of African descent are less than 10% of the population in the trial, which means that they are not adequately powered to show if there's a difference in response or not. Many people believe this is a fluke, and I would love for that to be true, but ultimately we have to prove it's true. And because ultimately we need to optimize treatment for every patient, and we need to understand how to do that. And so the jury is still out on this one. See, reply hazy, try again later. We hope to have that genomic data very, very soon. And I think ultimately, if it's not done, there need to be large trials in patients of African descent to understand what this finding was. And to pressure many companies to make sure they adequately represent these patients in our trials. So number two, same question except for a different regimen. This is the other FDA-approved regimen currently. Do we achieve the same rates of cure? Overall, you can see treatment naive, experience. Answer is yes. We have very small numbers because this phase 3 trial is not yet underway. But it will be done, and we'll have these answers. No one believes for any reason that we'd see a difference here. And you can see very early on, we are seeing very similar differences in cure rates over 90% again. So the 8-ball says signs point to yes, but we need more data to support it. And then this is the other regimen, declatosphere. So this is the one that will be approved in August. And again, phase 3 trial. I mean, these are amazing numbers, right, for HIV-positive patients. 12 weeks, 2 pills, 98% cure. I think they had 1 relapse in this trial. And there's a reason why this drug actually is a very good drug for HIV patients, and we're going to get to that when it comes to drug interactions. The issue will always be for a regimen that includes 2 drugs that are made by different companies will be cost. And that has been the big difference to me in being an HIV provider and now a Hep C provider, is this very, very significant difference at the approach of these drugs and approvals and the mixing and matching. It really isn't going on so well in Hep C, occurring very differently. But these are very exciting data. Overwhelming yes on this one. So let's get to the 8-week, because I think this comes up quite a bit clinically for those of you who are doing this. So this whole 8-week thing got to, if you're curing 99% of people in 12 weeks, clearly some of these patients should be cured in less period of time. And this is the big talk. Like, what would be the goal? The goal of treatment, everyone says, is 4 weeks. I can write one prescription, give it to them, say, take this, and we'll see you later. And that's certainly, from the point of patients having to come back, adherence, we know that every 4-week prescription leads to lapse in dose because it didn't get refilled, and you do lose adherence along the way. So that is a very important thing to think about. The question is it possible? So in this case, this is the lidosphere-sofosbuvir combination. They wanted to look and see whether or not you could do this in 8 weeks. And in fact, if you look at the numbers said it's exactly the same. But these are not virologic failures. These are patients who didn't show up and they got lost and they couldn't find the clinic or whatever. So if you look at relapses, which is what we care about, because every relapse is very painful for a patient. Relapsing is extremely difficult for patients because they put so much hope in the idea of being cured. And they get through treatment and their virus is undetectable, and then it comes back. And that really, to be fair, it sucks. So me, I say I have no appetite for relapse. That's my motto. I want to cure every single patient the first time around. And so you can see here, relapse was definitely higher. So the name of the game, the take-home point is, you shorten therapy, you trade relapse. And the question one is, does it matter if you relapse? And what's so you pay some more money to retreat that patient, but is there any other cost? And the answer is yes, and we'll get to that. So what you can see here is that someone did some nifty numbers, and they found that patients with a viral load less than 6 million actually got 8 weeks cured the same as patients with 12 weeks. So in fact, that's where the package insert comes from, 6 million. But any provider in the room here knows that there's never a single predictor that carries the accuracy where I would apply this to one of my patients, right? And then I'm going to show you data where some other company just presented 8-week data at the European Liver Meeting, and their cutoff was 4 million. Oh, well, that's nice. So what, everybody's going to have their own 4 million, 6 million? And the truth is, humans don't function that way. This is called cutting data. It's ad hoc. It's retrospective, and it's not generally how I like to do things. So I'm not a big fan of an ad hoc 8-week approach. This is from the Ally 2 study. This was the declatosphere-sofosbuvir. This is drug getting approved in August. These data were presented at CROI. This is in HIV-infected patients. This is not. This is Hep C mono. These are HIV-infected. They looked at 8 weeks. Look at this difference. 10 relapses versus 1. Now, there's some differences. They threw in cirrhotics and genotype 1 through 4. This is more complicated, but the bottom line is the story's clear. 8 weeks means you're going to relapse, at least with just 2 drugs. So I don't do it. Heck no. I wasn't sure if I could get away with the LL, so I put in the CK. But anyway, and this is, okay, look, I'm on the podium. This is my opinion. There are other people who are doing this. But you have to listen to me today, so that's the way it goes. This is just one person's opinion, but I personally feel that for now, I'd rather go 4 more weeks with my patients and cure them at 99 or 98% than put them at risk of a relapse. And we'll talk about why that is. But you look at the Ally 2 and co-infected, and they went back to try to do this game of HCV RNAs. What do you think they came up with? 2 million. All right, so 6 million didn't matter. But this is what providers are trying to make us do. And I understand this is a different regimen, but it really is kind of the same. It's the same drug. It's a great drug. Same it's NS5A. So, you can't say that there's much difference. I think the take-home point is these are just not things that you can figure out. And you certainly can't use one baseline predictor to make a decision about this. So I say no. Your insurers are going to try to make you do it, and I write nasty letters to say that this is not the standard of care, and that the ION-4, which is the phase 3 trial for that regimen, used 12 weeks, and usually we can get away with getting the additional 4 weeks, and that's what I would highly recommend. So I showed you the chart from the guidelines for patients that do not have cirrhosis, right? It was 12 weeks across the board, looked really easy. So here's the problem. Patients with cirrhosis, this is where we have a lot more work to do. And that is that patients with cirrhosis, it isn't as simple. It isn't as easy. These patients do fail, and they do need longer courses of therapy, or they need something more to decrease their risk of relapse. And there's one of 2 ways of addressing it. You prolong the treatment, or you add ribavirin. One of the 2. But the bottom line is that cirrhosis still matters. It matters pretty significantly, and that's why it gets back to this discussion of staging. Staging matters for 2 reasons now, because we treat patients differently and because they have to be managed for the rest of their life for their liver disease once you cure them. So this is just a take-home that's why this is so important, and that all of these regimens still offer these patients, whether naive or experienced, over 90% cure. So the SVR doesn't change. It's just the length of treatment or the need for ribavirin. That's the only difference. And that actually is still a huge measure of success, I think, for our patients. All right, so this is a slide that I'm happy to share with anyone, and it's really not mine. It's Jennifer Kaiser's, who's a brilliant PharmD at the University of Colorado. But this shows you where we have to go when it comes to the treatment of our HIV-infected patients. And the take-home story is everyone has some red. The more we start adding DAAs and combinations, 2 and then 3 and then 4, whatever, it's just going to make drug interactions with HIV drugs more complicated. So there is never going to be a really clean regimen, and then you have to make a decision as to whether or not you choose your Hep C regimen based on what your patient's on, or whether or not you switch your patients to get them on the regimen that you either want them on. I don't think any payer can force you to switch a patient's HIV regimen. I don't think they'd ever touch that with a 10-foot pole to get them on their preferred regimen because it's cheaper. I think that's actually a way that we can get around this quite a bit of not having to switch our patients. You can see that by far the cleanest drugs are declatosphere and sofosbuvir, where they kind of share this. No one uses taprenavir, so why would you do a study with it? Sorry if I offended anyone. But the bottom line is these are really clean drugs, and you actually have good data for them. But there are 2 points I'd probably bring home in the next few slides. So one is we get drug-drug interaction data, but it's critically important to do the data in actual patients with infection. And I think the Ally 2 is a good example of why. When they did their drug-drug interaction data, they found that when combined with boosted atazanavir, and I think darunavir too, they found that declatosphere doses increased. And what's interesting about declatosphere is it comes not as a fixed-dose combination pill with some other DAA, right? It comes as a 30 milligram, a 60, a 90. And so you can actually change the dose of the declatosphere depending on what the interaction is with your HIV drug, right? So they said, well, when you combine it with a boosted protease inhibitor, you should use the 30 milligram dose because they boost the dose of the declatosphere. And when you combine it with efavirenz, you should increase to the 90 milligram tab because the interaction decreases declatosphere otherwise. Well, then when they actually did the Ally 2 trial, they actually saw higher failures in patients on boosted darunavir. And they think it is, in fact, because lowering that dose of declatosphere wasn't a good idea. And so now the recommendation is to do 60 milligrams with these guys, 90 here, 30 here, and 90 here. But the beauty is you can actually change it, so you don't have to worry about switching your HIV regimen. Again, the issue is, this drug is going to cost, I'm sure it's going to cost more than, $3 a pill. And this one's pretty expensive, and so whether this combination will ever be used extensively, I'm just not sure in HIV patients. And you do have other regimens that can be used quite well in a majority of patients. But this is a really great tool, and this is, I think, on the AAS or the IDSA website. They pretty much mimicked this from Jennifer. So these are things to be very, very aware of. I'll bring this back as another example of why we learn different things and why it, in my opinion, of course, is what I do for a living, so I'm totally biased. Conflict, I do HIV Hep C, so I think it's really important to do phase 3 trials in HIV Hep C patients. But the bottom line is that when you look at the drug-drug interaction studies of ladiposphere in patients who didn't have HIV or Hep C, we found that ladiposphere levels were lower in patients on efavirenz. This is actually why we thought that the African descent thing was going to be pharmacologic. Tenofovir levels were higher in patients on efavirenz and rilpivirine. In fact, people based on this were taking patients off of efavirenz-based regimens when they were putting them on lead-saw. Tenofovir levels are higher with boosted protease inhibitors by 30 to 60%, and ladiposphere levels are higher with boosted atazanavir. So what did we find in the ION 4? Ladiposphere levels were exactly the same, regardless of the treatment regimen. And in fact, tenofovir levels were actually higher in patients on rilpivirine, and which was higher than patients on raltegravir, which was higher than patients on efavirenz. So in the end, the patients on efavirenz were the ones getting the lowest exposures to tenofovir. So these are really important things to know, right? And in fact, renal safety was confirmed in a majority of patients. And this shows you actually the actual pharmacology data. So this is actually why phase 3 trials in patients with infections. Patients who have infections of the liver metabolize drugs differently. Patients with infections metabolize drugs differently. I'm just a dumb clinician, but I think this shows you that. All right, for the sake of time, because I have like 1 minute, I'm going to skip through this because this is actually in the guidelines. But the take home from this is we still have one hole in patients that we can't cure at over 90%. And those are genotype 3 patients with cirrhosis. These days, no one wants to look at numbers that have a 5 or a 6 or a 7 or 8 in front of them, to be honest with you. And that's really where there's a bulk of the need for treatment for patients. So no doubt about it, genotype 3 is the most difficult to treat patient population. In fact, this is probably the only population where we're actually still using interferon. This is a study just presented at the European Liver Meeting, and they actually found that in genotype 2 or 3 patients, treatment-experienced cirrhotic geno3s, you can see 47% or 77%, which was quite high compared to the actual clinical trial that looked at this. They could actually get numbers as close to 90 as we've seen. And in fact, I still use, I mean, probably haven't recently knowing what's coming, but in the past 6 months, I've used interferon, this very regimen for my geno3s, because, you know, my motto is I have no stomach for relapse. And if I can convince my patients to take 12 shots of interferon, we can cure them and have them move on with their life. 404 error. No one really wants to talk about it. Still a little bit of interferon use going around, but I think it's well on its way out. So highlights of the European Liver Meeting were that we had some really great data regarding CKD and end-stage renal disease, a clear population where we have lots of HIV, and really a lot of concern about how to use these drugs. You can see here that we had a small trial using the AbbVie regimen, which is that the 3 DAAs combined, the non-nuke containing regimen. Very small numbers, still very early on, but 10 of 10 patients were cured and ultimately appeared to be safe. But I think what was extremely exciting was Merck has this dual regimen I showed you that will be coming in 2016. It's the nuke-sparing regimen. Actually performed extremely well without a nuke, which surprised a lot of us. But this is a phase 3 trial in patients with CKD and end-stage renal disease. It was pretty impressive. If you really want to look at virologic relapse, they only had 1. This is pretty exciting. So really good data. They actually only presented their first arm because it was a placebo arm that rolled over, but it was over 100 patients if I recall. So really great data. This is actually very, very exciting. And there's increasing data coming out as well with the ledipasvir-sofosbuvir regimen as well. So this is the word of caution. Does failure matter? Does relapse matter? Okay. So this is a study that presented at AASLD that looked at patients who had just failed a sofosbuvir-containing regimen, so a nuke, high barrier to resistance, really not significant development of resistance. And you can cure those patients when you add another DAA, in this case, an NS5A or ledipasvir. But this is retreatment of patients who had failed the combination of ledipasvir and sofosbuvir. And what you found was, in fact, the cure was only 70%. Okay, so we don't like 7s, right? 5, 6, and 7s. And what they really found was that it was the patients who developed resistance to NS5As that failed. So the new story is, as many people I think have believed for a long time, is that NS5As in particular, when you fail these multiple DAA regimens, you develop resistance to the protease, to the NS5A, not really to the nuke, but to the non-nuke. And it matters when you have an NS5A RAV and you fail. And so this is a problem, and it's something that we need to think about. So for me, well, I'll give them 8 weeks, and then I'll rescue them. Not so much. This study convinced me that for me, it's 12 weeks for all, until someone can convince me otherwise. All right. So last few slides. This is that phase 3 data I showed you again. Take home is 2 drugs, nuke sparing. This is their big meeting. Great numbers. Looks like a great regimen. Good competition. The Astral studies is actually from AASLD. This is the next round of drugs coming in 2016. So this will be approved in 2016. This will be approved. This is again the nuke plus just another NS5A, but it's pan-genotypic. Very similar to the decladisvir-sofosbuvir regimen that will be approved in August. And this will be very exciting, the idea of not having to worry about genotype. Very important in resource-limited settings, especially the idea of expanding this outside of North America and Western Europe. And then you get to, so where do we go from here? And I think these are the two of the big take-homes about what's possible. So this is triple, 3 drugs with a nuke. Okay, this is not 3 drugs because we don't have a nuke. This is 3 drugs because we do have a nuke. This was Merck's 2 drugs I just showed you that will be approved in 2016, plus sofosbuvir as their proxy nuke, because this company owns a nuke now, but it's in early development, versus Gilead, who has a nuke. They have an NS5A, and now they have a pan-genotypic protease inhibitor. And you can see when they went for 4 weeks, didn't look so good. When they go to 6 weeks, it looks pretty good. But, you know, to be honest with you, I don't even like looking at 94 these days. I really like looking at 99. But it does show you that there are patients who can be cured in very short periods of time. The question is, can we develop a way to understand who these patients are and who needs 12 weeks? But this is kind of where we're going. I think the future will hold 6 to 12 weeks of treatment for most of our patients with triple regimens. Elephant in the room, I've alluded to this, is the cost. Patients are being denied coverage for curable infection, prior authorizations and denials. How many of you have spent endless hours dealing with this? I generally say when a new drug gets approved, I add an extra 8 hours a week onto my time spent getting approvals for my patients. I mean, Duke doesn't even promote me. They sure as heck don't pay me for that, right? I'm just kidding. I love Duke. So this is the last slide. How do I get some of this stuff? And this is how our patients feel. The only treatment option he had under his current health care plan. You could ask the 8-ball, and it says, don't ask me, I'm a ball. So this is pretty much how I feel when I'm trying to talk to some medical director at some insurer payer. So anyway, take home is that patients with HIV achieve the same cure. Drug interactions are here to stay, but we can manage them very, very easily. Shortening therapy increases relapse. Relapse equals resistance, and resistance matters, at least for NS5As. Single baseline predictors have poor accuracy, i.e. the 6 million, 4 million cutoffs, whatever you want to choose. The goal should be to treat once, and liver disease management post-cures for life. And that's it. Sorry, I did go over.